Uh, Good evening, all doctors, and good evening, our today's Honorable Dr. Pramod Jog, and all the doctors who are present over here for allergic rhinitis and its management eCME with our international speaker, Dr. Pramod Jog. It's my pleasure to introduce our today's guest of honor, Dr. Pramod Jog. Uh, so I would like to present his brief introduction. He's MD DNB FIAP. He's a senior pediatrician practicing in Pune with rich experience of more than 35 years. He has a clinic and hospital in On. He's a director of Medipoint Hospital. He's a national trainer for allergic rhinitis and comorbids training module of IAP. He's the professor of pediatrics at DY Patil Medical College, Pune. He was also the president of IAP in 2016. He was standing committee member, International Pediatric Association from 2016 to 19. He was steering committee member, Gavi CSO from 2016 to 19. He was again the chairman of IAP Advisory Committee on Immunization from 2015 to 17. He received Plotkin's Prize for Best Performance in ADVAC at NAC France in 2011. Additionally, he is the senior consultant to UNICEF and also the chief editor, Times of Pediatrics. He has delivered innumerable lectures on national and international platforms and has more than 150 articles in reputed journals to his credit. So it's a great honor to have you on our platform, sir. It would be grateful to listen to you throughout the session, sir. And all the doctors, we are requesting this is Zoom platform. If you have any queries, you can unmute yourself during the session or post the session. You can ask directly questions to Dr. Pramod Jog. Over to you, Dr. Pramod Jog.
Okay, I will just start. Okay, so my dear friends, we will be discussing the topic on allergic rhinitis and the management. And it is very important because we are passing through the terrible times of COVID-19. And even if a single person sneezes in the vicinity, everybody starts running. And that's why on the queues and on the railway platforms and in the shops, if you want to get immediate place, you better sneeze so that people run away from you. Apart from the jokes, remember that the practice is also getting affected because people are wearing the mask so that the infectious diseases like the rhinovirus and the flu and all, they are going down and down and down. And that is why allergic diseases are going to increase because children are indoor. They are more likely to have indoor allergens as the cause of allergic rhinitis. Parents are also indoor, and that's why the indoor allergens are going to trouble everyone. So the practice of allergy and the allergic disorders is likely to increase in future. And that's why you can see that a new degree that every one of us will have to have is DTP. That is a daytime pediatrician. So we'll have to now concentrate more on breastfeeding and nutrition, immunization, and growth and development and allergy and allergic disorders. And we slowly and gradually may see fewer and fewer patients with infectious diseases. Okay. And I must give a disclaimer that neither am I allergic to anyone, nor do I have allergy for anybody. With that, let us remember that there is a significant health concern worldwide about allergic disorders. And in children, this problem is increasing. And the allergic diseases have reached a high prevalence in the last few decades. And these diseases are common in childhood, and they can cause a significant morbidity and impaired quality of life. Because a child who sneezes and sneezes and sneezes doesn't say sleep well, next day morning gets up late, again is sleepy during the school time, is a big problem. And as the child is unwell, even the family members are also under trouble. So let us see some initial cases so that we can start with the topic. Now, she's a girl, 11-year-old Ria, and she has recurrent cold for the last 6 months, and she has paroxysmal sneezing. Paroxysmal means she sneezes for 1 hour, 2 hours. After that, she stops sneezing. Again in the afternoon, she starts sneezing. and this sneezing is more than 50 times in few minutes. In fact, in my house, there is one of my close relatives who sets up an alarm with his sneezing every day in the morning. So as soon as the relative starts sneezing, everyone gets up in the morning. So there is not required any alarm in the morning. And that's why these are the people who have allergic rhinitis. I will just tell you one small little trick to remember. Those who get up coughing and coughing, they are asthmatics. And those who start sneezing after getting up, they are the ones with allergic rhinitis. Remember that. And some of them have symptoms which worsen in August or September. That is the particular season. And that's why these are the ones who have what is called as seasonal allergic rhinitis. While there are other ones who sneeze all throughout the year. That is called perennial. They are the ones who have some allergy to the dust mite, or maybe some pets in the house like cats and the dogs, and they are the ones who have perennial problems all around the year. Now there is another child, Sanu, 10-year-old girl. She has cough and cold off and on, but almost persistent for the last 3 weeks. But in addition, this particular child has fever and headache for the last 4 days, and the cough is more in the lying down position. So obviously, our clever listeners now remember that fever and headache and cough in lying down position could be sinusitis, and that is why, along with these symptoms of cough and cold, this particular child also has sinusitis. Remember, the age of the child is 10 years. You never diagnose sinusitis in earlier years of life as far as possible, because sinuses start developing after 6 or 7 years of age. There is Karna, 5-year-old boy with history of cough and cold off and on for the last 3 months. And there is history of fever, and additional symptom is earache, pain in the ear, 2 months back, which subsided with the course of antibiotics. But the cold and the cough do not go away, and it is always there. There is no breathlessness. So it obviously means that this particular problem, which is probably related to the allergy, has created some problem in the eustachian tube, which probably got blocked. There is earache, probably the one in the past disappeared, that otitis media, with antibiotic, but the problem continues. It means that there is involvement of the ear as a part of allergy. So there is another child, Astha, 3-year-old boy, girl, and then history of severe cough, cold, and sneezing for 15 days and recurrent for the last 4 months. A practitioner has given initially a course of antibiotic, and as you know, everyone receives nebulization as a welcome drink these days, and cough syrups are always given. And for the last 5 days, the child has received cough syrups, but the response is inadequate. There is no fever, but the cough and the cold persist. There is no chest sign, but this particular child has been put on an inhaler for the last 5 days, and the patient has come for a second opinion. Obviously, it means that there is a problem which is like asthma, and this is again additional problem in addition to the cold and cough. So along with these some cases, this is another case, Rohan, 10 years, who has runny nose with sneezing and rubs the nose often on daily basis for the last 3 months, and occasionally coughs in the night. There is snoring in the night quite often and has a disturbed sleep. Often the baby rubs the ear, but there is no fever. And mother is an asthmatic and on inhaled corticosteroids for the last 10 years and has had all types of cold medicines and many antibiotics in the past 3 months. Obviously, this case is a combination of so many things, which we will discuss again in details. So what I want to stress is that patients come to us with common symptom of recurrent cough and cold. Every mother will say, इस बच्चे को हमेशा सर्दी खांसी रहती है. Recurrent cough and cold, very common symptom. But there are additional pointers which are different in each patient. And that's why we cannot simply say this is allergic rhinitis. No, this is something else in addition to allergic rhinitis. And these confusing symptoms should be dissected out and they should be analyzed. And that is why careful history and examination is a must. Okay. However, we need to differentiate certain things. For example, we need to differentiate whether this rhinitis, that is watery rhinuria, whether it is allergic or whether it is infectious. We will see that in a minute. Whether this child has adenoid hyperplasia and otitis media, whether it is infectious or whether it is because of underlying allergy. So many children come to our clinics with, parents complaining recurrent cough and cold, recurrent cough and cold. So whether it is back to back viral infection or whether it is basically an allergic process which is getting exacerbated often, and that is why the evaluation of the ear, nose and the throat is extremely important in some of these cases. Whether this is allergic alone or whether it's a comorbid along with asthma, and this is why the treatment plan will change according to the condition. And that is why all these brothers and sisters of allergic rhinitis, the sinusitis, which makes it rhinosinusitis, the otitis media, then the asthma, so all these, they are all together. And that is why allergic rhinitis will never come as a plain simple allergic rhinitis. It will come with some of the brothers or sisters like the ones that I told you. And that is why one should know in the beginning as to what is indicative of allergic rhinitis. So remember, 2 or more of these symptoms for more than 1 hour on most of the days, that is allergic rhinitis. So what are these 4 important symptoms? Watery rhinorrhea, sneezing, nasal itching, and nasal obstruction. Remember, these are the 4 symptoms of allergic rhinitis, of which you need to have 2 or more. So the child will come to you for watery rhinorrhea with sneezing. So that is more suggestive of allergic rhinitis. In addition, if the child has nasal itching and nasal obstruction, yes, it much goes in favor of allergic rhinitis. And this has to be for more than an hour on most of the days. And that is why we should know which are the children who have some risk factors. So if there is a family history, that means in the family, there is someone who has some allergic disease, a boy, a baby who is born during the pollen season, the first born baby, early use of antibiotics. Remember, there is a term which is being used called as dysbiosis. Okay. So that use of antibiotics leads to dysbiosis and leads to allergic disorders. Maternal smoking exposure in the first year of life, relatively less common in our country. Exposure to indoor allergens like the dust mite, and some immunoglobulin levels of more than 100 international units before the age of 6, and some allergen specific IgE antibodies. All these are the risk factors of which one should know. As pediatricians, we should use antibiotics with lot of caution, only if required, in the first 4 years of life. Very important. And of course, the parents should avoid smoking. Remember, in India, there are certain important things which you must remember. In the rural parts of India, remember, they have high animal contact, high endotoxin levels in the homes, and this results in lower incidence of asthma and rhinitis and atopy. Air pollution, you must have seen so many children standing on the front of the scooter. The father or the mother, they want to drop the child to the school, but there is a traffic related air pollutant like nitrogen dioxide or sulfur dioxide or benzene. They are the ones which are implicated as the risk factors for childhood asthma. Tobacco smoke, which I just told you. Parasitic infestations, they are associated with reduced risk of atopy. BCG vaccination is beneficial, and breastfeeding and weaning give protection from allergic diseases. So in India, we have to remember some of these points. Now, remember that this allergic rhinitis affects 400 million people worldwide, and in the age range of 6 to 7 years, it is about 8.5%, and in the age range of 13 to 14 years, it is about 15%, and about 80% of individuals diagnosed with allergic rhinitis, they develop symptoms before the age of 20 years. And that is why the pediatric population is the one which we need to focus. Okay. Now remember that the quality of life is affected by allergic rhinitis. The sleep is disturbed, the child is fatigued, and then there are so many cognitive and psychiatric issues. Cognitive means understanding. Okay. So the child will develop attention deficit. The child will have low marks in the exams during the pollen season. The child will have poor concentration, which is either related to the disease or related to the first generation antihistamines if someone has prescribed. Remember, the REM sleep, rapid eye movement sleep, as all of us know, is associated with the sensation of good sleep. Okay, so if that REM sleep is disturbed, which happens in these conditions, then the child doesn't feel that the sleep is over. Okay, so there is also impaired athletic performance, and that is ultimately what leads to a low self-esteem. So the child feels that there is something wrong with him, and we need to take care of all these issues. Okay, at the same time, you must know as to what is not allergic rhinitis. Okay, so remember, if the symptoms are unilateral, there could be a polyp or a foreign body, it is not allergic rhinitis. Only nasal obstruction, it is not allergic rhinitis. If the discharge is mucopurulent, okay, if there is pus, posterior rhinorrhea, that means I told you in allergic rhinitis the rhinorrhea is anterior, while in case of sinusitis there is posterior rhinorrhea, that is called postnasal drip with thick mucus. And along with this, if there is pain or recurrent epistaxis, or if the child is unable to smell, then obviously this is not allergic rhinitis. These are the chaps who need to be referred to an ENT surgeon. Now remember, I just told you that the commonest reason for a child coming to us for runny nose is either a common cold or allergic rhinitis. Okay, so a common cold, which is because of rhinovirus or influenza virus or parainfluenza, any virus which affects the upper respiratory tract, there the cold will last only for 7 days, 1 week only. There will be presence of fever. There could be constitutional symptoms like headache and body ache. And we all know that influenza is associated with all these constitutional symptoms. The nasal mucosa in these children is red, and these children may not respond well to antihistamines. And along with this child, other members in the family will be affected. So Dr. Jog is unwell, his wife is unwell, his children are unwell. So that is common cold. While allergic rhinitis, the cold will not be over in 5 or 7 days. It will last for more than 10 days. There won't be any fever. There will be signs of allergy. The nasal mucosa will be pale, and the child will respond excellently to antihistamines, and all the members in the family will not be affected at one time. Just to impress upon you, this is the pale blue inferior turbinate. Inferior turbinate is the one on which, of course, we all are going to point our intranasal steroids also. So remember, on the lateral wall of the nose, where the inner part of the ring, you must have seen so many women wearing some jewelry in the nose, and where it comes on the inner side, that is on the lateral wall of the nose, that is the point where there are inferior turbinates. So they are pale blue. Okay, and you can see on the left side the pharynx also shows an appearance what is called as a cobblestone pharynx. Okay, so in addition to all this, there are some symptomatic clues beyond the nose. Not only the nose, but we have ocular allergy. So the child will have watering of the eye, itching of the eye, redness of the eye. And 60% of patients with allergic rhinitis have this allergic conjunctivitis. Some children might have had eczema, atopic dermatitis in the earlier age. Some of them might have fullness of the ear, as I told you, related to the blockage of the eustachian tube. And some of them, they complain of palatal pruritus, itching of the palate. So they will take their tongue continuously to the palate. Okay. And remember that young children typically do not blow their nose. Adults will blow the nose. Okay. Instead, these children, they repeatedly snort or sniff or cough and try to clear the throat. Okay. And as I told you, some of them will scratch their itchy palate with the tongue. And this produces what is called as a palatal click or a clicking sound. Okay. And remember the symptoms of the comorbidities that I told you. So if there is sinusitis, the child will have headache, bad breath, that is called halitosis, cough in the lying down position. And if the child has adenoids, the child will have snoring, mouth breathing, hypernasality of the voice. The voice will be nasal. There will be otitis media with effusion and uncontrolled asthma. Remember, in the COVID times, we all have witnessed that people lose the sense of smell and the taste and all. We have to be very careful. If a child has loss of sense of smell, one has to be very careful when they analyze a child who has allergic rhinitis with sinusitis. Also remember, these people who have sinusitis, which is infective, they have halitosis, that is bad breath. And my teacher used to tell me, Pramod, these patients, they give very bad odor, bad breath to the others. They themselves cannot smell it. Okay, that is the tragedy. Anyway, remember that. And that's why 4 major symptoms of allergic rhinitis, I am repeating: sneezing, nasal itching, rhinorrhea, and congestion. Now, why all these things happen is because of the chronic inflammation of the nose, which is induced by IgE antibodies after allergen exposure of the mucous membrane. So there is initially a sensitization. Okay, so many people come to us, they say, sir, because of the fish, this particular child has some allergy. But when he ate the fish for the first time, nothing happened, because the first time when the child had something, there was sensitization. What happens is the antigen, for example, a pollen, when the pollen is inhaled by the child, that is sensitization. So the IgE antibodies are produced in the first instance. Again, there is exposure to the pollen. And then there is the second time. After this particular situation, the IgE antibodies are again there. But these two IgE antibodies, there is cross linkage by the antigen, that is the pollen. And that happens on the surface of the mast cell. And these mast cells, they release histamine. And histamine is the main culprit in the causation of allergic rhinitis. And that is why wherever there is runny nose, itching, sneezing, all these things are the manifestations of nothing but histamine. And always remember, the first instance is sensitization. So in the first 1, 2, 3, 4 years, this child will get only first sensitization, but the manifestations will be in the latter part of life. That is why first year, second year, you don't diagnose as allergic rhinitis. You diagnose allergic rhinitis at a later age, because initially there is sensitization and later on there is re-exposure. And 5 to 25% of children in the world, they are affected with allergic rhinitis. And this is something important that all of us must know. There are, some children who have a typical allergic march. What do you mean? In the first year of life, they will have some allergy, say cow's milk protein allergy. This problem related to the GI tract will slowly disappear. This is shown in the red color. There are some children who have eczema, atopic dermatitis. The mother will say that the doctor had prescribed something to be applied to the cheek, something to be applied to the shin of the tibia. These are nothing but the steroids, local steroids. So these children also recover after 1 or 2 or 3 years. Preschool wheezers, the asthmatics, they will start in the preschool age and they may continue throughout the life. And if you see the violet colored bar, you can see that is allergic rhinitis. If you see it starts after 3 years, 4 years, 5 years, the peak is somewhere in the adolescence. Okay. And this is something that you must remember. So the symptoms are according to the age. Okay. So any child coming to you for allergic rhinitis, please ask for runny nose. I am repeating, it's a clear watery discharge. If it is purulent, it is sinusitis. If it is a post-nasal drip, it is sinusitis. Remember, there is also paroxysmal sneezing, nasal itching, associated nasal block, watering of the eye, itching of the eye, redness of the eye, atopic eczema, asthma-like symptoms, and family history of allergy. So your history will not be complete by only asking about the nasal symptoms, but other symptoms also need to be asked. And you can see some pictures where this child has itching of the nose. This child is called an allergic shiner. If you see below the eye, there is venous congestion and darkening. Between the nasal bone and the cartilage, there is a transverse crease. This is allergic salute. Every one of us has own way of satisfying the nose. So this particular child has an allergic salute, and this is very classical. So many times I feel that in the exam, in the MBBS or in the MD, we get cases like rheumatic heart disease and then some rare syndromes, but no one ever gives a case of allergic rhinitis to the students as a long case. In fact, so many things are there which could be seen in a child. We can ask whether he has mouth breathing, which indicates adenoids, rubbing the nose, frequent sniffling or throat clearing, allergic shiners, and so many things which I told you. And then a person should also palpate sinuses for the tenderness, maxillary tooth sensitivity, then pneumatic otoscopy to assess the eustachian tube function, Valsalva's maneuver to assess for the fluid behind the eardrum, and in the posterior oropharynx, as I told you, one can look for postnasal drip, lymphoid hyperplasia, which gives cobblestoning, tonsillar hypertrophy, and wheezing in the chest. So many things to be seen. So it's a detailed history and examination. And the symptoms in the nose are grouped into two, the sneezers and the blockers. So those who have runny nose, sneezing, there is paroxysmal sneezing with watery anterior rhinorrhea with nasal itching and conjunctivitis, which is worse during the day. Okay. And that improves during the night. So those who have watery discharge, they sleep well at night. But those who have blockage, we have seen so many advertisements on the media about, some inhalants which are usually given at night. Okay. So they have little sneezing, but the mucus is very thick. There is severe congestion and they are worse at night. And remember, our antihistamines will take care of the sneezers and the runners. Okay. The sneezing and the itching and all. But the inhaled nasal steroids or the intranasal steroids are the ones which will take care of all the symptoms. So the blockers, particularly, they require either decongestants or the intranasal steroids. Now, earlier people used to classify allergic rhinitis into seasonal and perennial. Okay, I just told you that. But the allergic rhinitis and its impact on asthma, ARIA area classification, is the one which gives you division into 4 categories. So imagine that a child has a mild problem. What is mild problem? The sleep is not disturbed, the activities are not affected. This is a mild problem. While another child who has a moderate or a severe problem, the sleep is disturbed, the activities are affected, the child is sleepy during the daytime in the school. So either the problem will be mild or it will be severe, and both these categories could be either intermittent or persistent. So a child who gets a problem less than 4 days in a week, remember the figure 4, okay, and less than 4 weeks in a year, is under intermittent category. Okay, but if he has more than 4 days a week, more than 4 weeks in a year, he goes into persistent category. Now, why to classify rhinitis into all these? This is because our management depends on this classification. So a child coming to us could be mild allergic rhinitis and coming to us intermittently. Comes in February, then comes in June, then comes somewhere in November. It doesn't come very often, and at a time he has only 1 or 2 days of a problem, but he keeps coming intermittently. While there is some child who has a problem all throughout 1 month, 2 months, 3 months continuously, and that too very bad. So that is a severe variety which is persistent. So it's very easy to understand. And remember, our child number 5, the case that I told you, which was a combination of so many. So that child Rohan, who has a runny nose and sneeze and rubs the nose. Okay, so that is allergic rhinitis. Occasionally coughs in the night. He has snoring in the night quite often and has a disturbed sleep. So as he is sneezing, in that classification, he is a sneezer. Okay, as he has a problem for 3 months, he is moderate to severe persistent. Okay, and there is also rubbing of the ear, which probably indicates serous otitis media. And an additional pointer to the allergic rhinitis says the mother is asthmatic on inhaled corticosteroids. So try to put these children into phenotype. Phenotype means allergic rhinitis, a sneezer, moderate to severe because it affects the activity, and then persistent. So all these points are to be told and they are to be assessed. Okay. So just remember that you will ask me as to how to find out whether this is really allergic rhinitis or no. Remember, the diagnosis is clinical and the routine lab tests are normal. So there is no need for you to send all these children for a hemogram. Neither the peripheral blood eosinophil count nor the total immunoglobulin E level, okay, is sensitive enough to help the diagnosis. IgE level is elevated only in 30 to 40% of patients. So please do not send these patients unnecessarily for a checkup. Only if a child is less than 2 years, then remember it is less likely to be allergic. I told you the problem is after 3, 4, 5, 6, 7 years. So if the child comes to you with symptoms related to nose, then be sure that you first rule out ENT abnormalities, so many disorders which are under the age of 2, and all these pointers to some other disease. Okay, so remember, my dear friends, that the diagnosis is clinical, and the diagnosis, as I told you, when 2 or more of these symptoms, the obstruction, secretion, sneezing or nasal itching for more than 1 hour a day for more than 2 weeks in a year, as I told you, because of allergen mediated cause that I already told you. Now, allergy skin testing is something which some of our colleagues, they do. Basically it confirms that the patient is sensitized to aeroallergens. What are aeroallergens? The ones which are in the atmosphere. Okay, but it is not necessary for the initial diagnosis. If you are not able to come to any diagnosis clinically, the child is not controlled, then you can go ahead with that. Now, what is the natural history? What happens to these children? Allergic rhinitis requires a few years of allergen exposure to develop. I already told you. That's why it is uncommon in children under 2 years of age. And if a very young child has persistent nasal symptoms, please consider other disorders. Okay, and after the age of 2, the prevalence of allergic rhinitis steadily increases, and there is a bimodal peak in the early school and the early adult years, and the condition is persistent throughout the adulthood with some improvement in the old age, but it uncommonly presents for the first time in older adults. So if after 40, 50 or 60 somebody comes, it is less likely to be allergic rhinitis. Okay, There are certain skin tests which are done. What they do is that they will do it on the skin, particularly if the diagnosis is unclear. And when the antigen is injected, if there is a wheal and that's more than 3 millimeters, then usually the diagnosis is made. This is done by some of our colleagues who expertise in allergy and immunology. And whenever you are clueless, please see that you refer them to some of our colleagues, because it is always better to share the responsibility, and it is not the area wherein you should intrude into. So if the symptoms are poorly controlled, or if there are coexisting problems like asthma or recurrent sinusitis, it's better that you refer them to your colleagues who are experts in doing the allergy testing. Of course, it's not the topic for discussion today. I am just giving you a broad outline. Now, to give the plan of management, remember T1, T2, T3, T4 and T5. If a child comes to you with only intermittent problem which is mild, use non-sedating H1 antihistamine, okay, like levocetirizine, okay. So if at all a child has only intermittent problem, then please use non-sedating H1 antihistamine, okay. If a child has further severe problem, uncontrolled, go for inhaled or intranasal corticosteroids. If the child is still not controlled, go for the intranasal corticosteroids with intranasal antihistamines like azilastine. And in case if there is still no control, then you can use oral corticosteroids and an additional treatment. And if it is very bad, then you can refer to a specialist for immunotherapy. This is a general plan of action. This has changed. In 2020, the area guidelines also have changed in the management. Earlier, there were quite a few other molecules which were involved in the management, but here it has been very, very simple, and we'll discuss one by one. So histamine, as I told you, is the most important mediator of allergy, and that's why antihistamines are always going to be there, okay. There are different generations of antihistamines, and all of us know that the first generation ones, they have central effects which will cause drowsiness, and that's why it will impair the cognition. Cognition means understanding. The child will not understand what is going on in front. The doctor will not understand what the patient is saying. So that is cognition, understanding, okay. The second generation antihistamines are preferred because they have few adverse effects, and they are more selective for the H1 receptors in the periphery, okay. And there are some second generation antihistamines. They also have additional anti-inflammatory effect, which occurs by decreasing the production of cytokines. Now, the oral H1 antihistamines in the first generation, all of us know, are chlorpheniramine maleate, diphenhydramine, promethazine, but they are associated with drying of secretions, drowsiness, all these anticholinergic effects, and cognitive impairment, and they should not be used in the management of allergic rhinitis. In the market, we have combinations of CPM along with some other product like phenylephrine, and they are the ones which should not be used in the management of allergic rhinitis, okay. Now, the second generation antihistamines are the preferred drugs. They are not associated with drowsiness, and they have minimal side effects. And remember, I told you that antihistamines, they will reduce itching, sneezing, rhinorrhea, but they are less effective for the treatment of nasal congestion as compared to the intranasal steroids. And this is a list of medications with the dosages, which I think is not necessary for the august audience in front. Looking at these particular slides: cetirizine, loratadine, fexofenadine, levocetirizine, desloratadine, ebastine, and bilastine. These are the second generation ones. Now remember that the sedation with levocetirizine is lesser than cetirizine, and medication like fexofenadine, bilastine, which are also available, they are also associated with less of sedation. So remember that there are other groups of medications called as topical antihistamines. These are the antihistamines which are oral. Now, topical ones like azilastine, they are delivered by the nasal spray. They also have a very quick action, but they have a very bitter taste and some irritation, drowsiness, and they can be used above 5 years. They are azilastine and olapatadine. Remember, the dose is 1 spray per nostril twice daily. Remember, you'll ask me, when do we use antihistamines nasally? Remember, I told you in the T1, T2, T3, T4, T5 that if the control is not there, even with intranasal steroids, then you may consider use of these antihistamines nasally for a period of 1 to 2 weeks. However, in pediatric practice, people usually do not use nasal antihistamines. This is something in the arena of the ENT experts. Okay. Montelukast is a leukotriene receptor antagonist, and it is useful for treatment of children of allergic rhinitis with asthma. And all of you know that the dose up to 5 years is 4 milligrams, 5 to 10, 5 milligrams, and about 10 milligrams. Just remember that the intranasal steroids basically is the first line therapy for moderate to severe allergic rhinitis. As I told you, they are effective against all the symptoms, and they are the most efficacious medication for allergic rhinitis. The onset of action is between 5 to 7 hours of the dose, and the maximum efficacy requires up to 2 weeks, and they are 100% appropriate if there is a symptom of nasal blockage. Okay, and the quality of the life score improves with the intranasal steroids than the oral and the topical H1 antihistamines. However, it is important to choose the intranasal steroids with low systemic bioavailability. What do you mean? We are dealing with steroids, and that's why they should not go in the system. And that is why the systemic bioavailability should be low. And these are the ones like mometasone furoate, fluticasone furoate, fluticasone propionate. They are the ones to be used. And beclomethasone, triamcinolone are to be avoided. Okay. They have negligible side effects even after long-term use, and the compliance and the technique should be checked. I told you that one should clear the nose of the secretions, insert the nozzle into the nostril, and direct the spray laterally on the lateral aspect of the nose inside from the septum towards the ear. You know, you must have seen the movie by James Bond some few years back. Of course, those who are now in their 40s or 50s must have seen. So the right hand is directed to the left side, and the left hand is directed to the right side. Similarly, the intranasal steroids, if at all you are using your right hand, the spray should be directed to the lateral aspect of the nose inside. I told you, ladies wearing the jewelry in the nose, the inner part of the metal where it comes, that is the place of inferior turbinate, and you have to spray for a little distance. Okay, so that it spreads little on a larger area. And remember to use the right hand to spray the left nostril, left hand to spray the right nostril. This is important. And there are medications like intranasal decongestants like xylometazoline, oxymetazoline, which are effective in the nasal obstruction. So this is something like relief medication or a rescue medication. At night, many times patients, they call us, sir, bachcha so nahi raha, naak band padi hai. It's for a temporary relief, and it should be used only for a short term of 5 to 7 days, because they don't improve the itching and rhinorrhea. They only remove the block, and the prolonged use results in tachyphylaxis. That means the same drug stops becoming that much effective, and there is rebound congestion. And we know the term, that is rhinitis medicamentosa, which we used to use when we were students. Okay, and then there are some oral decongestants like phenylephrine and pseudoephedrine. They are not recommended. Please don't use them, because they have effects related to the alpha receptors and arrhythmias. So please keep away from some of these medications. Most important in the management of allergic rhinitis, of course, is the environmental control. And I told you that there are triggers which are outdoor allergens like the pollens from the trees and the grass and the weeds, and the indoor ones, the house dust mite, the fungal molds, the pets, and the cockroaches. Now these are the living items. Okay, while there are irritants, for example, the father comes with a nice little perfume and the child starts sneezing. Okay, there is a parent who is smoking and the child is sneezing. Mosquito coil, cooking fuels, and air pollution. So all these are the irritants. They are non-living things. Okay, so they are triggers and irritants, and they have to be avoided. It is important that you know a bit, because you have to tell the parents. So the pollens are basically seen in the duration of 11 a.m. to 5 p.m. As the heat increases, the pollen count increases. Okay, and as the altitude increases, the pollen count decreases. So I jokingly tell some of my friends who are having allergic rhinitis to go and stay in the Himalayas, so that they won't be affected by allergic rhinitis, because Himalayas are a high altitude. Remember, when there is increase in the air pollution, the air pollution and the pollens together become more dangerous. The potency of the pollens increases 50 times when there is associated air pollution. Okay, so remember that pollution and pollens, they are a bad combination. Remember that. Now inside the house, there are what are called as the house dust mites. What are these house dust mites? They are the very microscopic creatures which are on the bed sheets and the blankets, and you can see, you know, the carpets and the curtains. And remember, whenever you have a person who has allergic rhinitis, these bed sheets and others have to be washed twice in a week. Okay, the heat is very important. So you put all these blankets and other things in heat. Whenever there is heat, the dust mite doesn't survive. But the heat required for some of these is about 130 degrees Celsius, which is very hot. Warm water doesn't remove them. And periodically, please see that you clean these. And there are suggestions that these bed sheets and others have to be in a good quality plastic, so that during the night time they don't create the problem of allergy. This is important. Remember that we have to be very careful, because the night time, 8 hours out of the 24 hours, the child is on the bed, and that is why you must take proper care of the room where the child is sleeping, and the dust mites have to be taken care of. In case if there is humidity, there is fungal mold outside the bathroom or on the walls, be careful. Many patients who are allergic to the fungal molds. And pets, what to say about pets? Management of pets is a very interesting area. Remember, many people have cats and dogs in the house, but remember, cats are worse than the dogs. Okay, both these animals, they will pass urine, and sometimes if they lick, the saliva will also touch the skin. When the saliva dries up, then the allergens are released, and that produces allergic rhinitis. Remember, the cats are worse than the dogs. Even if there is a cat in the neighborhood, that will create a problem. We all know that cats will come inside the house, they will drink the milk and go out. But when they play inside with children, many times they will release their dander, and that will create more amount of problem. So remember that cats are the ones who are worse than the dogs. Okay, cockroaches. Remember, in case if you find that during the daytime there are cockroaches inside the house, it means that the house is full of cockroaches. If cockroaches are seen at night, it's okay, but if they come out during the daytime, it means that there is the limit has been reached. Never crush the cockroaches. Okay, if you crush the cockroaches, the antigen from the cockroach, the allergens, they will flow off in the air atmosphere. That will create more problems. There are related to the pets, and please remember that you have to be very careful. However, some of our parents, they don't like that we tell them that don't keep the pets in the house. They will change the pediatrician, and they will never remove the pets from the house. So please tell them to manage the pets accordingly. As I told you, quite a few children go to the school on the scooter. Now, in the non-COVID times, you will find they will be exposed to the atmospheric pollutants. When they come home, there is a mosquito coil, there is a cooking fuel, and indoor air pollution. So all these are to be taken care of. And remember that immunotherapy is allergy vaccine, and this therapy will lead to disease modifying effects and modifies the underlying cause of allergy. Okay, so there are short-term and long-term benefits, and there is a sustained effect even after the treatment withdrawal, and it is useful in allergic rhinitis and asthma. But an allergic skin test is a prerequisite. And the immunotherapy controls the symptoms and decreases the sensitivity by sequentially increasing the dose of antigen to induce a shift of the immunological response from Th2 to Th1. This you must remember. And they are indicated if there is moderate or severe persistent allergic rhinitis, if there is inadequate response to pharmacotherapy, unsatisfactory compliance, and inadequate response to the environmental control. Remember that. And there are two types. One is subcutaneous immunotherapy, and other is a sublingual immunotherapy, which we are not going to go in the details. I will elaborate a few points about the comorbids. One of them is allergic rhinitis and asthma. 30% of allergic rhinitis patients have asthma. 80% of asthmatics have allergic rhinitis. Remember that. Many times patients come to us with uncontrolled asthma, and then we realize that this chap has allergic rhinitis, which is a risk factor for asthma. And allergic rhinitis and asthma, they share common allergens, and proper treatment of allergic rhinitis will improve the asthma control and the pulmonary function test. Now you'll ask me as to how it happens. This is called as a unified airway concept. So if you see, the histamine, which is responsible for allergic rhinitis, also has a property of narrowing the airways. The patients with allergic rhinitis have increased number of inflammatory cells. Patients with asthma have changes in the sinuses, and the treatment of allergic rhinitis improves the symptoms of asthma. So it means that both are connected, and that is why it is called as a unified airway disease. That means the allergic rhinitis and asthma are nothing but a part of the unified airway. Okay. Remember some points about sinusitis. As I already told you, the correct term should be rhinosinusitis, and the symptoms are nasal blockage, nasal discharge, which is anterior plus posterior, because rhinitis means anterior and sinusitis means posterior. There is halitosis and loss of smell. There is facial pain, headache, and ear pain. And remember, nasal inflammation with allergic rhinitis causes obstruction of the sinus osteomeatal complex. What is the reason for sinusitis? This is the obstruction of this osteomeatal complex, and that is why there is predisposition to the bacterial infection. And remember, if there is allergic sinusitis, the X-ray of the sinuses is not specific. The mucosal thickening could be very well allergic or infectious, and the CT of the sinuses gives greater details but doesn't tell you about the etiology. It's also expensive, and the treatment of allergic sinusitis is same as allergic rhinitis, but bacterial complications have to be watched for. So if there is a thick mucopurulent postnasal drip which is persistent for more than 14 days, if there is fever, headache, and facial pain, and a cough in the lying down position, then one needs to treat properly for 14 days. No 3 to 5 days therapy. Sinusitis means 10 to 14 days. And the underlying allergy has to be kept in mind. And if there is a severe deviated nasal septum with obstruction, or a glued ear, or refractory sinusitis with adenoid enlargement, or obstructive sleep apnea with adenoid enlargement, nasal polyps which are not responding to the intranasal steroids, you better refer them to the ENT surgeons. Okay. Now, in the case that we discussed, the investigation showed that the total count and the differential count was normal, and the final diagnosis was allergic rhinitis, moderate to severe, persistent with serous otitis media. This chap was put on mometasone nasal spray, one spray in both the nostrils at bedtime. Allergen avoidance measures were explained, and at 4 weeks, the symptoms of the sneeze, rhinorrhea, nasal blockage, they decreased by 80%. The sleep was comfortable. There was no coughing at night, and the ear also showed resolution of the medullary fusion. And this child was advised to continue the therapy for 12 weeks. So my dear friends, remember one important thing, that in area 2020 guidelines, there is something called as a visual analog scale. You can see that the picture of the face will tell you whether it is mild, that is 0, 1, 2, moderate, that is 3, 4, 5, 6, 7, severe, that is 8, 9, 10. And depending on the score, less than 5, more than 5, the treatment is planned. This is particularly for the adolescents and the adults. And one should remember that this is called as a visual analog scale, which we will not discuss in details today, but just remember this is according to the area 2020 guidelines. Okay. So my dear friends, allergic diseases are common in childhood, and they can cause significant morbidity and impaired quality of life in children and the families. So look out for cardinal symptoms, watch out for the comorbids, rule out or treat infections, use oral second generation antihistamines and intranasal steroids depending on severity, treat allergic rhinitis so that the asthma control improves, and specific immunotherapy if there is inadequate response to the pharmacotherapy. So my dear friends, with that, remember that recently on the Valentine's Day, one of my young college student friends, because I keep going to the medical college, he offered a rose to his Valentine, and instead of smiling, the Valentine started sneezing because she was allergic to the pollens from the rose. So please remember, when you offer some flower to someone, remember it has to be very, very carefully done. Okay, because it could be a re-exposure after some initial sensitization. Anyway, with all this, I thank you for a patient listening, and in case if there are any questions, please feel free to ask. Thank you.
So there are questions. There is one question from Dr. RPS Chawla. He's asking role of saline nasal drop. What is the
Saline
role
nasal
of
drops have come into vogue, and there are some new products which say that there is washing out of the allergens from the nose, and there are few clinical trials in our country, but there is no harm in using saline nasal drops. The point that I told you was about oxymetazoline and others, which can produce rebound congestion, and that is why saline nasal drops, okay, no problem, you can use. Okay.
Doctor? If any other questions, you can unmute yourself and you can ask.
Okay, that's also fine. I already told you that allergic rhinitis is a very, very interesting topic. In fact, we have not discussed the other allergic disorders like atopic dermatitis or allergic, problems like urticaria. We have not said about that. I have restricted today only to allergic rhinitis, and maybe in future we can discuss about other allergic disorders. Remember, allergic rhinitis is underdiagnosed, while infectious rhinitis, common cold, is overdiagnosed and overtreated. Okay, this is very common. So you should remember that there is no need of treating with antibiotics. Simply when a patient says that there is runny nose, you should in fact be happy that this is either viral or allergic. So keep away from antibiotics. Secondly, one should always tell the parents that allergic rhinitis is controllable. It is not curable. Please remember that, because many parents come to you with a great expectation that it will be cured, but it is not so. It has to be clearly told that it is controllable. It is not curable. Okay, so these are some of the important things, and parent education is extremely important. One other important thing is the calculation of the total dose of the steroids. Many times uncontrolled allergic rhinitis, these children also have uncontrolled asthma, and these children are either on inhaled corticosteroids for asthma or intranasal steroids. Okay, so one has to calculate the total dose because it may go into excess. Some of these areas, they come in the arena of our colleagues who expertise in allergy and immunology, and it is always better to refer and to have a second opinion of our colleagues who are working in that field, because many times our colleagues have a lot of experience with different allergens, different situations from different parts of the country. For example, the house dust mite, it is different in the four different zones of our country. So one has to have some knowledge. Today, what I did was an overview so that you must get some idea as to what is allergic rhinitis and what is the plan of action. Now, sky is the limit for you to go ahead and have your own experience and read more about all these topics. So in case if there are no further questions, I think we can disperse. And from my side, I thank you again for a patient listening.
Thank you so much. It was really a wonderful session, Dr. Pramod Jog, and thank you all the doctors who have taken their valuable time and who have joined us today for allergic rhinitis and its management, eCME. So I would like to inform all of you that our next eCME is on 13th of March on approach to prolonged fevers by, again, same our international speaker, Dr. Pramod Jog. So see you soon on 13th of March, sir. By the time, take care, stay safe, stay healthy. Thank you. Thank you, everyone.
Thank you.